My name is Nuno Lobo Antunes. I'm a pediatric neurologist, and I'm the clinical director of CADIM, the major child and adult developmental center in Cascais, Portugal. And my role here is to ask questions, actually to purvey your questions to this illustrious panel of experts, and we're very happy and to have such well-known people who have been working for a number of years in this field and are well-known worldwide. So I would probably start with Amy Klein, and since I have the microphone, I'm going to ask my own question first, okay? I would be two questions. I'm very interested in the possibility of making very early diagnosis in autism spectrum disorders. And my feeling was that your goal was to achieve this through looking at the way very young children, infants, look into people, and namely to their mother's face, eyes versus mouth, and so forth. My question is, these kids, these infants, would their own mothers pick them up and say, there's something wrong with my child?
Would the mothers feel that way?
Yeah.
Well, being a parent is not something that you learn sort of from one day to the next. And so it typically sort of varies from parent to parent. Parents who have had other children typically have a point of reference to judge their relationship with a child who is vulnerable. But it is interesting that historically, the main reason for parents to be concerned about children who eventually have autism has been things such as delays in speech, and that typically happens when the children are reaching about 15, 16, 17, 18 months. But thanks to increased awareness around the world, really, parents have become much more aware of concerns that they may have with children in the first year of life. So nowadays, parents may tell us that the child is not engaging with them, is not responding to them. All of those kinds of responses that we know should precede the more well-known referral questions, such as delayed speech. Whether they actually feel that way, it's really a question of what do you expect from interacting with your child. And for many parents, they don't expect that there's anything wrong with their children. And in many ways, I think not only parents of vulnerable children, but all parents often fill in for the blanks left by the children. And we tend to play both sides of the equation in many different ways. We scaffold an interaction that would appear more reciprocal. The main issue that we are seeing that parents are becoming more and more aware is the lack of contingency, that the children do not appear to be reacting to their approaches, and they're becoming more aware of that. I should say, however, just to address one issue, yes, the research that I presented to you yesterday had a lot to do with the visual modality. But we're also researching the auditory modality because there are sort of auditory mechanisms of socialization. And we're also researching an area that it's totally neglected in the field, I think, which is haptic social interaction. As parents, we spend a lot of time handling our children, and babies are extraordinarily aware of this kind of intersubjective transmission of love and of social engagements, really, through touch. So I'd like to just correct this impression. I don't think at all that issues of socialization have to do only or even primarily with the visual modality. We choose the visual modality because it is easy to manipulate. But I see the issues of socialization as something that is what we call supramodal. It's beyond a modality.
Well, yeah. Well, my question is that, of course, you cannot screen every single child with technology for autism. So you have to pick the children who already had brothers or a family history of autism. And in that sense, mothers probably would have a previous experience. So my question is, under those circumstances, would the mothers be as good as technology in order to pick them up, these kids? That was the...
Oh, I see. So I'm sorry. So it was lack of my theory of mind. We've been working now with parents of children, parents who already have a child with autism, and we are seeing the younger siblings, and we are seeing those siblings from birth. We know from previous research that we expect maybe between 2 and 10% of those children would also show some kind of developmental problem. Some of them may actually develop autism. Our group, as well as many, many other groups in the United States, in the United Kingdom, and other places in the world, in Israel, what we've been finding is that the rates of developmental problems is actually greater than we expected. Now, working with those parents, I can tell you that there is a tremendous amount of anxiety. So they are hypervigilant. And in many different ways, the work that we do during the first year of life is more one of reassurance. And the very fact that they are part of those research studies, in ours, for example, we are seeing their children on a monthly basis, is reassuring to them. And yet the amount of anxiety is tremendous. And indeed, they are acutely aware of any deviation from an expectation. In fact, they are often too worried. But you can never say that you're too worried when you already have a child with autism, and here's a sibling who is at greater genetic risk for it.
Now, let's assume that you can make a diagnosis of autism in a 6-month-old child. What would then change? What would change in terms of intervention? I mean, what is really the difference? What difference would it make if you make a diagnosis at age 6 months or 18 months?
I would say that we're not aiming at making diagnosis of children at the age of 6 months. Our group, as many other groups, we all know that there is tremendous variability in outcome, not only if we were to identify vulnerability at 6 months, but at the age of 2 years. As we see those children at 2 years, and again, at the age of 4 years, some children make great progress, some children don't make any progress at all, and our field is still not good to sort of make predictions on the basis of early developmental processes. Our goal is to mark vulnerability. And if we are able to mark a vulnerability, then we do have to ask the question as to what we do. That's a tremendous moral imperative. I think I can predict to you that for quite some children, we might be able to identify vulnerabilities in the first year of life, but we still don't know what would be an empirically based form of intervention. All of us have guesses, but why do we do that? We do that because the most rapid period of brain development and of cognitive development in the life of a human being is really the first year, the first 18 months of life. There is tremendous neuroplasticity that unfortunately diminishes with time. It never ends. As we heard yesterday, we would love to teach our children, our adolescents, and our adults forever so that we maximize their outcome. It is still the case that the earlier, the better. That's the general sort of the statement that one can make, even though we cannot say that this is going to work for every child.
Sure. Feel free.
In Scandinavia, they claim to have developed a very early screening tool. I don't think they're yet calling it a diagnostic instrument, which claims to pick up autism or autistic-like conditions at 9 months. One of the difficulties is that then it raises ethical issues, again, about what you do. You can't just go around and say this child may have difficulties and then bye-bye, we'll monitor him. And so, of course, they have instigated a program. But, of course, that means they can't really test how good their instrument is, because you don't know if the child would have gone on to develop autism. You could say it's because they've developed this program that the child has, so there are big practical and ethical issues around it. But their program is based really on a lot of social interactive programs that, develop the world round. In the UK at present, we have a big trial of PACT, which is, again, working with parents to help them relate better to their children. Now, that's for slightly older children, but you could put the age back and you could actually, you know, we certainly have techniques, programs that are based on very early interaction. The problem is, well, I think the main issue in those programs is getting people to wait longer. That seems to be the crucial variable, that you disrupt the interaction between a mother, let's say, and the baby if the timing is wrong. And the timing nearly always seems to be wrong in autism. And if you can actually get the mother to adjust the timing by waiting what for her is an uncomfortable length of time, it doesn't feel natural, but waiting for the baby's response that bit longer, then I think, and it's just a supposition, I have no evidence to support this, but I think then you might be able to get that interaction going on the baby's terms, because we certainly know later on that people with autism need longer to respond, but their responses can be more typical, if you like, if we allow them on their terms.
I have a question for Sarah, and I think this is a very common concern and a very common question. This lady says, I have a son with Asperger syndrome. Now, what are the chances that my second child will have it as well?
Well, currently we say the recurrence risk, or the chance that a second child would have something similar, is of the order of 2 to 3%. So, you know, if you had 100 children, 2 or 3 of them might. But having said that, up to 10% or 15%, 10 to 15% can have a very mild, what we call a broader phenotype. So one aspect of an autism spectrum disorder. So perhaps some problems with social communication, some problem with language, or some problem with repetitive interests. So it's very difficult to say in each case, but that's the sort of, so we say, you know, to have a severe autism recurrence or Asperger syndrome would be of the order of 2%, and to have something milder of the order of sort of 7%, and then something very mild of the order of 10 to 15%. But each case is different, and now with the discovery of new genetic abnormalities in the genome, sometimes if we're giving that recurrence risk to families, it may be too high. So if your child has a genetic abnormality, for instance, that is the first occurrence of that abnormality in the family, it may be that another child will not have that genetic abnormality, and the recurrence risk may be much lower. So that's really the answer.
I have 2 other related questions to that. Now, everybody knows that some of these kids have an autistic regression. Right? Some of them are autistic right from the start, if you wish, and others have an autistic regression. Are the genetics different for each of these groups?
Well, we don't know to date, and currently approximately a quarter of children in the autism spectrum, or certainly on the severe end of the autism spectrum, will have had a regression. And currently they're all lumped together. And genetic studies haven't yet subtyped according to those that have been a history of regression, those that haven't. So we can't say to date whether there is a difference or not.
Any explanation why is Asperger's syndrome much more common in boys than girls?
Again, we don't know. We don't know to date. I mean, we've looked at the X chromosome, which is the automatic sort of place to look. So at the basic molecular genetic level, there isn't any evidence that the X chromosome is showing genetic variation in boys who have just one X chromosome compared to girls. But it may be that there's a protective effect of some of the female hormones on neurodevelopment. and that some other protective factors in girls, in females, to do with their hormonal system are interacting with genetic expression and acting as protective factors.
Yeah.
I just wondered about the David Skews study.
Yes.
And for those of you who don't know, he looked at the Turner syndrome, where there's only one X chromosome, and girls with only one X chromosome. And I think the findings, or maybe I'm simplifying them, where that X chromosome came from the father, the girls were okay. Where it came from the mother, the girls had a social difficulties. They may not have met full criteria for autism, but they had social problems. And I wonder if you wanted to comment on that.
Yes, and the suggestion was that there was some imprinting or epigenetic phenomena which were, altering the expression of X chromosome genes that were coming from the mother. To date, nobody's sort of replicated that or found any supporting evidence for that sort of hypothesis. But I guess the jury's still out, and we'll wait and see.
I've always wondered about that hormone theory, because even in children who have autistic regression, there are more males than females. And it's hard to understand how the autistic features develop at age, let's say, 2, and still imply that was the hormonal medium that caused it. And there are still more boys than girls. Can you comment on that?
Well, I don't know. I mean, in terms of autistic regression, is there strong evidence that there are more boys than girls?
Do you mind if I comment a little bit about regression? I'll just comment a little bit about regression. This is one of those findings that is really worth going and looking carefully into it. There is the sense that a group of maybe as high as 25% of individuals with autism have regression. Now, that's a very strong statement, because when we talk about regression, we think about this very, very, very rare condition called child disintegrative disorder, when the child is developing entirely normally, and at a later stage in life, could be at the age of 3 or even later, there is this dramatic regression, and at the end of which the child is indistinguishable from a very intellectually disabled child with autism, and the outcome is in fact worse than in autism. That's everybody would recognize. The notion that we have a large percentage of children who have autism, who have regression, is based on some studies that looked into the fact that children had a few words and then lost them. And sometimes we're talking about 5, 6, 7, 8 words. And so even though this is something that, of course, we need to pay attention to, I would still question that this is true regression for the following reason. For those of you who have ever worked with congenitally deaf children, you know that even though those children can't hear anything, they are babbling away. They are making sounds. They get to a point in which there is no feedback. They can't hear themselves. And so what happens is that the babble ends because it's not serving any function. Biologically, they are babbling, and they no longer do so. So I would suggest that we should not discard the possibility that some of our children with autism who have the so-called regression may also be vocalizing, and they may be copying sounds, and they may be using sort of basically those sounds that we recognize them as words, 5, 6, 7, 8, 9 words. But because they are not serving the purpose of communication, in an analogy with the case of congenitally deaf children, that those children are no longer talking, because the vocalizations that they are making are not serving the purpose of communication. The reason why I mention this is because there are some findings in autism that we should not take for granted. The notion of a regression in autism takes us to a completely different model of what autism might be. Not unlike, for example, a metabolic disorder, something that is accumulating, it crosses the threshold, then you have the disorder. So what I'm just saying that we should not take it for granted. It's something that the studies that are not being done retrospectively, but they are done prospectively by following the children from birth all the way through the time in which the diagnosis can be made reliably, those studies are going to actually answer the question of regression in autism.
Yeah, but I don't think we should discard them as well, because that's certainly a clinical experience. Not only we're talking in terms of vocalization, but also in socialization. I mean, this child, she used to laugh at me, she looked at me, and suddenly things changed. And actually, Gilmar, who's here, has a large experience with possible mitochondrial disorder in these children who regress, because they tend to have higher lactate and pyruvate and ammonia than kids who are autistic right from the beginning. But I think that the main point here, though, is that perhaps if you look at epidemiological studies, you shouldn't put autistic children together as a whole, and perhaps isolate some subtypes in order to do the study, because otherwise, that would be my impression.
Yes.
Would you like to
Yes.
comment on that?
Yes, I think it's very important. I mean, in order to increase the power to detect anything, I think we're going to have to be refining our phenotypes, probably according to language, IQ, perhaps a regression. I mean, just a comment about regression. I mean, something that might be quite helpful in teasing out the etiology of regression is if in these longitudinal studies that are prospectively following children from birth, if one could have built into those studies some sort of metabolomic or collection of urine so that one could then track, and those that did seem to develop regression, look at sort of the gene-environment interaction in their urine, a simple thing to collect a urine sample, and see what's going on immediately prior to the regression, if you see that as part of your longitudinal studies.
I'll just say that this is actually part of the protocol that is used by the Autism Speaks and the National Institute of Child Health and Human Development. Those data are being collected. If you don't hear any results, it's because they've been analyzed and there is very little to write home about.
Okay, good.
Well, I have a very important question to Rita Jordan here. How does ABBA compare with other strategies? What is the best strategy for
group?
Yeah, what is the role of ABBA, applied behavior analysis, in the treatment of autism compared to, let's say, teach programs, floor time, you name it?
I really wish it was a program about ABBA. I could sing for you and it would be much more pleasant. But sadly, it's ABA. Okay. ABA, is such a misused term. It's a very broad term based on learning theory, which assumes that all kinds of learning is the same. It's a very popular theory from the 30s onwards. And it began to be used with learning disabled groups in the 60s. And when I first worked with children with autism, that's all we did, because that's all we knew what to do. And to some extent, it was very effective. It is effective for certain things. But children with autism are children, and they're human. And there's never been a group of any human individuals that only learn in one way, and therefore that only need teaching in one way. And, we should not stop thinking about, does this child need ABA or floor time or whatever. We should think about our goals. If you want a child to learn to conform and to sit down and do some tabletop activities, and sometimes that's a valuable thing to learn, especially if the child's all over the place and doesn't get any centred, it's a good thing to learn to sit down, and you get good results quickly, which encourages parents and staff to work with the child and so on, gives hope. So a lot of good positives. Then ABA's, there's no point in learning new exciting ways of getting dressed every morning. You might as well have an ABA program. That's okay. But if you want a child to problem solve, if you want a child to think for themselves, if you want a child to interact with people, if you want a child to get fun from the world around them, not to be frightened, not to be scared, to put a child in a situation all the time where they are having to obey, where they're having to conform, where that pressure of, being under someone else's control is there, that's terribly stressful and not very good for their learning. To me, that's not education. We need to think of the goal, and the goals will change as the child develops. At some points, this is the priority goal. At other points, other things are. So I think we should stop all this argument. There's so much work to be done, so many good things to be done. You know, no one's got all the wisdom. And, you know, what people often call a science, you know, ABA proponents are very often clean to say we're the only scientific method. Well, actually, I think they're talking more of a religious cult. You know, they have a strong belief, they have charismatic leaders, they all follow the doctrine, you mustn't deter, but, you know, we need to look at it again. There are good things. I know some wonderful ABA therapists. I know, you know, parents who say that they were the first people to give them any support and to help them meet with other parents, you know. So lots of good things have happened around ABA programs, but we shouldn't sell our souls to one approach.
Here. This, I think, is a very important statement, truly. And thank you for having made it. I have a question for Pilar Martín, and the question is around the association between Asperger's syndrome and attention deficit disorder.
Well, quizás esta pregunta la deberíais de responder tú, por ejemplo, que eres el especialista. ¿Por qué no la respondes tú? Yo lo que tengo en la experiencia clínica mía como psicóloga, efectivamente, es que aunque el síndrome de Asperger, por criterios jerárquicos o cualquier trastorno dentro del espectro del autismo, no admitiría el diagnóstico del TDAH, sabemos que en la práctica clínica se hace y que existe una comorbilidad alta entre ellos, y que creo que es importante tratar el trastorno por déficit de atención y hiperactividad cuando realmente es comórbido con el trastorno por síndrome de Asperger. Pero tú, como médico, quizás, y que sé que tienes estudios sobre la comorbilidad, podrías responderla también.
Well, I have the clinical experience, and I can tell you what I think about this subject. Of course, if you're talking about, you know, DSM-4, you don't have attention deficit if you have autism. But the truth of the matter is, when you have an autistic child, they often have an attention problem, okay? It is hard to sometimes to tease out if this attention problem is really primarily an attention deficit, or basically the child is concentrated in his own feelings, thoughts, and so forth. So in my clinical practice, if I'm in doubt, I'll medicate. I mean, I'll try methylphenidate or whatever and see what results I get. And, you know, it's easy enough. And I think that in the majority of cases, it is helpful. It is helpful. So as a model, as a construct, you have problems. But in practice, I believe it is very common. But by the way, I think that hyperkinetic children below age 3 years, you have to be very, very careful, make sure that he doesn't have an autistic spectrum disorder. Because I think it's quite frequent to have children who are tremendously hyperkinetic, and one thing has ADD, ADHD, and in fact, once you took care of the attention problem, the social deficits and the autism spectrum disorder comes up. This is certainly a very common experience to me. Would you care to comment on this?
Happy to. What I would say about the young children, it's a complex matter, and I think you said it well. But about ADHD and autism. It is indeed the case, and that for many children that construct is very, very, very relevant. But we always have to be worried about context. There are some times when we are assessing a child with autism, and the child is really a model child while you're doing your IQ test, because it's structured, it's explicit, you're doing something that they love it, and they are just there. They have absolutely no problem with attention whatsoever. And then you finish your IQ test and you start your diagnostic interview. and you start asking the question like, tell me about your friends. And then the child is on the table, below the table, is around the room, is running out. So in many different ways, I think that we just need to be smart in terms of thinking that whether or not this is a biologically driven attentional and hyperactivity problem, or it is a contextual issue. And for some of our children, they pay not attention at all to things that we would like them to attend to, and they pay too much attention to things that we don't want them to pay attention to. So indeed, it is the case, and there have been clinical trials of the positive effects of things such as the particular agents that you've mentioned. It's a fact. It's been shown. But for some children, the clinicians should always ask themselves the question whether this is at all contextually driven. Because our children, like any children, their behavior will vary depending on the context that they are in.
Yeah, I would fully agree, except that sometimes it's not easy to decide. And it's always a problem with attention deficit disorder anyways, in the sense that even a child without autism, but with attention deficit, will pay lots of attention to his computer games. So, attention is always something directed, task-directed. So sometimes it is difficult. Again, for Pilar, the question is, children with conduct disorder have an intention to hurt. Is it possible for kids with Asperger's syndrome who have behavioral problems also to have this will to hurt, as in conduct disorder? That's, I guess, the general sense of the question. Because they sometimes misbehave, right?
Yo no lo he visto. Yo creo que sí que hay una diferencia en la intencionalidad que tiene el niño con un trastorno de conducta y el niño con un síndrome de Asperger. Por supuesto, el niño con síndrome de Asperger puede tener trastornos o alteraciones de conducta, pero en mi experiencia clínica, no sé lo que los otros pensarán, y si hieren a alguien es porque realmente no han entendido bien el contexto social o las reglas sociales que tienen que estar siguiendo. Creo que tengo yo un caso de un niño muy que seguramente os identificáis con vuestros propios pacientes. El caso de un niño que algunas veces presento en los congresos porque se le expulsó de un colegio por ser agresivo, por haber pegado a otro niño, pero realmente él efectivamente había pegado a otro niño porque el otro niño le había saludado con una palmadita en la espalda y él lo interpretó como una amenaza, como que ese niño le estaba atacando primero y él devolvió. Esa ha sido mi mayor experiencia en los chavales con síndrome de Asperger, que no tienen esa intencionalidad de herir a alguien por el placer de hacerles daño o por el placer de conseguir una identificación con un grupo social, como puede hacer el chaval con un trastorno de conducta, que a través de la agresión pues, puede ganar puntos en referencia a su grupo social. Yo no lo he visto en síndrome de Asperger, pero yo no sé, Rita y Ami, que trabajan más también en la clínica, si lo habéis visto.
Okay, I have a question. I don't know to whom address this question, which is actually a very important one. It's about the influence of TV programs in social competence, habits, violence, and personality of children with autism.
I'll start, but I'm sure other people will have more erudite things to say. I think it's not just television, of course, it's computer games, it's the internet and all these things. There is an effect on attention, as we have just said, and we are increasingly worried in the UK about all our children growing up, as someone has graphically put it, with the attention span of a gnat, because that's what, even our children's programs now, every few minutes they are something new, because their sustained attention is not being followed. People with autism often get a tremendous amount from learning from televisions and from computer games. And it can be put to good effect. The parents had a child who was obsessed with videos. Instead of, trying to stop him watching videos, they actually began to use videos and make videos as educational tools. So they had a lovely little program involving his sister and so on, showing him what, this is Jenny's shoes, this is Granny's shoes, this is Mummy's shoes, and then, Jenny eats, and, all verbs and adjectives. And he loved it, and his family loved it, and it brought them all together. Instead of being a big issue of discord, it was a training thing. So that can be very good. The danger with, I think, more of the internet than with television is, of course, misunderstanding. And when, especially some men with Asperger's syndrome that I have known, very lonely, desperate to have a girlfriend, and then seem to find, perhaps not a bad thing, find some solace in some websites, but maybe not interpret them adequately. So if you see some voluptuous ladies on some sites that say they're available, then their expectations of what they're going to get from a relationship, from a girlfriend or from going out, they expect girls to be available and they expect them to look in a certain way and to behave in a certain way, and then can get angry and frustrated when that doesn't happen. In extreme cases, and I would stress it's a very extreme, I only know of one case where it happened. You do get much more worrying things, but, I guess I'm sure that happens with all kinds of population, but I think we just need to be watchful in autism. And that's where a lad, because he couldn't get a girlfriend, he became interested in necrophilia. That's, sex with dead people. And I don't know these things, but apparently there are whole websites on the web devoted to this, and there's lots of material out there. And he became obsessional collectors of this material. Anyway, I won't go into the very sad tale, but he ended up trying to kill somebody in order, I presume, to have sex with her. So, it's a tragedy for everybody, a tragedy for his family, obviously a tragedy for the girl's family who he attacked and the girl and so on. So to avoid the potential of such tragedies, we do need to perhaps monitor and have some feedback, know what our children or the young people or even the adults are watching and give them a forum for talking about it and for making sense of it.
You want to add anything, Clem?
I'll add a tad just to another question, because it's something peculiar to the United States, but something that maybe it has happened elsewhere. In the United States, for decades, people who were cognitively intact, meaning they were high functioning and they had a social disability, there wasn't a name for that. And so people tend to have those individuals labeled emotionally disturbed, which is basically an euphemism for conduct disorder, which is a psychiatric diagnosis. Because they got themselves in trouble, and so they had bad behavior, so they have conduct disorder. And so what happened is that people followed up on that in terms of recommendations for treatment and even placement. And here's a situation that happened only in the United States. You have individuals who get themselves in trouble, okay, they engage in bad behaviors, but they understand others quite well. In fact, they can manipulate others. They don't care about others. Now, those individuals are the perfect victimizers. Now, put them together with those individuals here who also get themselves in trouble, but they get themselves in trouble because they don't understand the rules of the world. They don't understand people very much, and they get themselves in trouble. They are transgressing those rules entirely unaware. They are the perfect victims. If you put the perfect victimizers together with the perfect victims, you have the perfect misplacement. So that happened in the United States for decades, and sometimes individuals that we follow for years have dreadful tales to tell about how much they have been victimized because they were wrongly placed in those environments because somebody was not smart and somebody characterized the issues as an emotional disturbance, which was the bridge to a conduct disorder, and they were totally unaware that they had actually a social disability. So this is just a little note about that question.
Okay. I have a question here about medication. I don't know who wants to answer this question, but basically what's the role of antipsychotics, namely neuroleptics of last generation, is risperidone, and also antidepressants. I don't know if any of the Spanish members of the panel want to talk about this. Otherwise, I'll do it. Go on. Okay. Well, there is really no medication for autism. Although I do believe that perhaps we'll get there, in the sense that Irish whiskey certainly increases my ability to socialize. I'm talking about myself, so that must mean something, right? Having said that, obviously medication is useful for a number of features, problems in people with autism spectrum disorders. Of course, methylphenidate and other psychostimulants are useful often. Risperidone may be extremely useful for anxiety, aggression, and other problems that come together with the core of autism. So it's certainly must be done case by case, very well thought of by an experienced clinician and so forth. But there is a role for medication, certainly in children with autism. And risperidone is often useful. I haven't found antidepressants as useful, as a matter of fact. Although it may be, and other medications may be used for self-mutilation and things of the sorts. So yes, definitely there is a role for medication.
Can I comment on that?
Yes.
Desde mi experiencia, yo soy psicóloga clínica, entonces, pero trabajo en un equipo de psiquiatría. Y yo sí que he visto diferencias bastante significativas en los adolescentes que presentaban una agitación interna que no era falta de atención, era más como una respuesta de ansiedad. Ellos lo describen como eso, agitación interna. Y esa agitación les ha podido llevar a presentar unas conductas bastante alteradas, que te pueden recordar un poquitito a las conductas que puede presentar una persona con un episodio psicótico. Jóvenes que además han empezado a elaborar ideas quizás relacionadas con la persecución, un poco de que voy al instituto y que los compañeros me miran específicamente el pelo y eso se convierte en una obsesión para ellos y les determina la conducta. Y realmente en esos jóvenes, cuando yo he intentado intervenir con métodos más psicológicos, no ha funcionado. Y cuando se les ha puesto en tratamiento farmacológico con el Risperdal, esa agitación interna ha desaparecido. Y al desaparecer la agitación interna es también como un efecto dominó, va como desapareciendo la intensidad de esas ideas que no llegan a ideas delirantes, pero que llegan a unas ideas muy sobrevaloradas. Y nos ha permitido trabajar o bien a los psicólogos o bien a los educadores en lo que es el manejo a nivel de aprendizaje. Pero en mi experiencia no lo hubiéramos podido conseguir sin esa ayuda farmacológica. No, por supuesto, en todos los casos, pero en estos casos que estoy escribiendo yo también creo que hay un rol muy importante para la medicación.
Okay, I have here another very important question. At about what age should a child know that he has a diagnosis of Asperger's syndrome?
I think we had yesterday, yes.
No.
I think we had this yesterday, so perhaps we could...
Okay, move on. Miklaine, is it possible that a child, a baby, an infant with Asperger's syndrome has a different kind of cry?
Derek Ricks.
That's a short answer. Absolutely. Do we know? No, we don't. But one of the things that there's a lot of research going on with babies. And what people are trying to do is to take 50 years of developmental science, people have been studying babies for a long time, and bring that knowledge to bear on research of autism. And so we talked a little bit about the various protocols, including metabolic protocols. But one of the things that people are trying to do is to be clever at measuring those things. So in our group, for example, we have a whole programmatic effort to understand and to measure, to quantify both the production of sounds as well as the perception of sounds. My colleague Ria Paul is professor of communication disorders. She is looking into all of those issues, including the notion that there is something of value in terms of crying. But not only that, if there's something of value in terms of early babbling. And one of the things that we know is that babies don't simply do things. They do things in response to others. And I'll give you a brief example. Some of the studies that I showed you yesterday, we have babies looking at videotaped caregivers. And yes, we believe that this is better than showing them static pictures of faces. When we go around the world, we don't see sort of static pictures, we see people. Having said that, that's very different from interacting with a live person. And as we began to do studies of live interaction, meaning the baby with his or her own mother, one important thing began to happen. The babies began to vocalize, which means that the vocalization is not simply an outpouring of sounds, it's also already the beginning of an interaction with the other. And so we would expect that those kinds of data should provide us with some information about the ontogeny of social engagement, and by extension, something that is useful to trace the derailment of that, if that's what's occurring early on in autism.
Yeah, sure. It's now very old. It's about 35 years old, I think. A study by Derek Ricks, which I think has never been replicated, when he was working with Lorna Wing. And that's when they took the cries from 4 typically developing babies in 4 different situations. One was surprise, sort of a pleasant surprise, a sort of balloon thing blowing up or whatever. One was greeting, the first thing in the morning when you came into the cot, the noise that baby made then. One was hunger, demand sound when they saw their food being prepared. And one was frustration when they were about to be given their food and then it was taken away. Obviously didn't have such strict ethical committees in those days. But then compared them with 3 children with... and interesting enough, 3 of the babies were English babies, and 1 was a Spanish baby of Spanish parents. And then they had 4 other children, 3 of them with autism and 1 with Down syndrome. Okay, so that made 16. Did it? No, we're up to 8. 8 4, 32 sounds, which were jumbled up and then fed back to the parents. And the interesting thing was that all the typical developing sounds could be interpreted by all the parents. Okay, they could, but the parents couldn't tell their own baby. Okay, so they could understand what the sounds meant, but they couldn't pick out their own baby. When it came to the Down syndrome, they could also understand the sounds the baby made, and again they couldn't pick out the baby with Down syndrome. It was slightly older than the typical babies, than the babies with typical development. When it came to autism, in general, the parents could not understand the sounds that the babies made. But this time, the parents could each identify their own baby and could understand what their own baby meant, but couldn't understand the other children with autism. And the conclusions that Derek and Lorna made at the time, a small amount of data, of course, perhaps needs looking at, was that right from the beginning, the children with autism were making different sounds. Now, what happens is that the parents, their own parents, get to know their own baby and what their own baby means but they're not typical sounds. And that probably has an implication of how the response, because parents are going to take a time to get to know their own baby and so on. So it may have knock-on effects. But that was, perhaps needs replicating.
So I guess birds do a much better job in recognizing his children sounds or whatever. I don't know who wants to answer this question. I actually, this is the point. When you talk about ADD, for instance, you think that perhaps the 4-to-1 difference in terms of incidence from boys to girls possibly comes from the fact that many girls with attention deficit are not hyperactive. So they are much more difficult to pick up. Their delay in diagnosis is 4 years in relation to boys. Can that be an explanation as well for the difference in incidence between boys and girls in Asperger's syndrome? That is, you see, perhaps 20 boys for every girl. I mean, it depends on the series. But is it possible that there is a female syndrome of a female type of Asperger's syndrome that one is missing?
In the UK, Elizabeth Newson developed a notion of pathological demand avoidance syndrome, which in the beginning she said only girls had, and people began to talk about that as the female form of Asperger's syndrome. I think the position has now changed, and she's saying that some boys also have it, but it's predominantly girls. Whether it exists as a phenomenon, I don't know. I think as far as I know, there's only been one published case studies. In the UK, it's only diagnosed by people who have been trained by Elizabeth. So it's a narrow group of children who are diagnosed as having it. But that's one suggestion. The other is Sheila Wolf's loners, when she traced through the life studies of certain people, including girls. And again, people were thinking maybe these are, maybe it's not a typical way in which it expresses, but these are girls who, if they were boys, they would be said to have Asperger's syndrome.
Just a comment on the ADHD. I think there's been a number of studies, including ones by Eric Taylor at the IOP, which have looked at the symptom profile in boys and girls and have found them to be exactly the same. So the symptom expression in girls doesn't necessarily account for the male to female difference between boys and girls in ADHD. I mean, I don't know, I can't comment about Asperger's in the same way. But do you want to come back on that?
Yeah, well, I think it's also from clinical experience that the girls have less of hyperactive subtype. They have more of the inattentive subtype, and that certainly makes things more difficult to diagnose, because if you are a kid who's jumping all around and making all sorts of noises, you bet the teacher is going to say something. Now, if it's a girl that's looking at the teacher but her head is away, it's much more difficult to pick up. And I think that's in my clinical experience, that's more common in girls than boys, for sure.
Yeah, but I think the empirical data, though, doesn't support, say, the clinical evidence that there is more of the inattentive subtype in girls than in boys, that the subtypes are similar across all perhaps more of the hyperactive, impulsive subtype in boys. But certainly the inattentive is similar in boys and girls, and they combined similar in boys and girls, but perhaps more of the hyperactive, impulsive in boys.
Right.
Yeah.
Aren't all developmental difficulties more common in boys? Isn't that a fact?
Yes, because I think it's true. No, I mean, what I was going to say, I'm not going to say it, but
no.
Sometimes very exquisite equipment is easier to break down.
Yeah. But can I comment on that?
I mean,
isn't it true that boys neonatally have a higher mortality rate and seem to be more susceptible to all environmental influences, certainly early in life, whether that's an immunological or other deficit?
And in general, if you look at any traits, boys perform at the extremes. It's also true there are many more male geniuses than females. females tend to cluster in the middle of, normative curves. Males tend to be at the extreme. So what that means, I don't know in evolutionary terms or biological terms, I'm not sure. But certainly, Michael Fitzgerald has written a book which equates autism, maleness, and genius. And he does a lot of sort of parlour games of going back in the past and saying, so-and-so probably had autism, which is not really particularly scientific. But I think, there is quite an accumulation of evidence about the extreme. And, of course, there's a lot of duplication in girls. Males lateralise earlier, don't they? So they have better spatial skills and so on, whereas girls then have language represented in both hemispheres more and, things like that, so that if there's a single hit, the girl tends not to get it. The girl needs a double hit in order to often get it, because there's nothing to...
And certainly in terms of IQ, there don't seem to be any male-female differences from the epidemiological data sets. But however, in mathematical abilities, boys do tend to do better.
Yeah.
So
and
they
obsessional activities, which you need to be either to have autism or to be a genius, you need to be somewhat obsessional.
Oh, yes.
And males tend to be more obsessional.
Well... Well, you must understand that the Gauss curves does have a lot of... so you're talking about medians, all right? But still, my point is...
Vive la différence.
No. Look at specific learning disabilities as dyslexia, for instance, which is something very easy to measure, okay? Number of words read, number of mistakes, and so forth. The incidence is almost equal in girls and boys, okay?
Dyslexia, no?
It's a little more in boys, but it's not by far. The difference is not by far the same as in ADD or autism, okay? So my point is, maybe the difference is not so high. Maybe we're missing this diagnosis in girls. So that's the point I was trying to make, or to ask you. Is it possible that because some degree of having just one or two friends would be acceptable for a girl, or even being looked upon as a good thing, you're missing some girls with Asperger's syndrome? That is my question. And the second would be, could it be there is a specific profile of Asperger's in females? That was the other question. And I think, because one of the problems with DSM-4, from my point of view, is that we're talking about developmental disorders, and yet you have a set of diagnostic criteria which is fixed and not age-related or gender-related.
Bien, yo, centrándome en la primera parte de la pregunta, si realmente se diagnostican menos chicas en edades tempranas o no, y que por tanto los datos de incidencia o de ratio por sexos fuera diferente. Los datos dicen que son iguales los ratios por sexo en edades de niños y en edades de adolescentes y adultos. O sea, es decir, que no hay un cambio en esos ratios, o si lo hay es muy pequeño. Quiere decir que aún pensando en la posibilidad de que la manifestación del conjunto de síntomas presente un cuadro peculiar en cada grupo de sexo, los síntomas están. Y esas diferencias de ratio, de número de niñas frente al número de niños, se mantienen en las diferentes edades. Por tanto, yo no sé si es posible pensar en un perfil que cambie la combinación de síntomas, aunque claro, cada persona es única y por tanto habrá diferencias también por sexos.
I'm not going to invalidate any of the various comments. I think that everybody really has a theory about that. But I would make a pitch for a book by a very good friend who is an anthropologist and who is also a parent of a child with autism. And his name is Roy Richard Grinker. And he wrote a book called Unstrange Minds. So he was an anthropologist in Africa. He learned a great deal about cultures in Africa. But then he had the child with autism. And he became very interested in the perception of autism in different parts of the world. And because he is married to a lovely lady from Korea, he started studying the perception of autism in Korea. Now, in Korea, it's unacceptable for you to have a child with any biological impairment. And so it was more culturally acceptable to define those mothers as mothers who had not taken good care of their children. And so we had the diagnosis of reactive attachment disorder being given all over the place there. And he studied the perception of autism in many different countries, and then he came back to the United States and said, you know what, I have something to add to some of the trends that we've been seeing in autism on the basis of culture. The reason why I make this pitch, it's because culturally we expect different things from males and females. And we also tend to pick up problems differently on the basis of those expectations. And so I would just add to the biological, the genetic, and to many other sort of theories that we have about the gender ratio in autism, the cultural one, because that's yet another complicating factor.
Very good. That's a very important point. Thank you. I
just say we should remember that when we're teaching as well.
Right.
I think we have far too many women teaching boys how to behave like women. And we do a lot better, and they'd learn a lot faster if we actually taught them to socialise like males socialise. It's much easier, and they wouldn't be so odd. You know, we need. Brenda Smith-Miles has made this point very well in some of her books. But we need to look at what we're doing and look at how males socialise with one another. They behave differently with women. But if you look at the research on how males socialise with one another, it's much more, around a task. They don't just sit and, engage one another in deep conversation. They always have something to do, and generally they do it all together. They all shout at the television screen together. Well, we can train kids with autism to do that very much easier than we can train them to talk about their feelings and so on.
It's very primal.
Yes, I was just wondering if Annie could comment on bring up children in that sort of early, and men are sort of more disposable, as it were. And so, because of the fecundity issues and Asperger's and advantage for males.
Well, I'll have to change subject, or otherwise I'm going to finish right here.
I'll address that, Sarah, later.
Oh, well.
Can I comment? Muchas niñas no están identificadas, sobre todo las niñas que están en el grupo del alto funcionamiento. Las que quizás se ajustan más a la definición diagnóstica del DSM-4, del síndrome de Asperger. Y esto está basado en mi experiencia clínica, de haber trabajado con diferentes equipos de diagnóstico en 2 países diferentes. Y con las niñas siempre hemos tenido muchas dificultades, a pesar de que hemos utilizado las evaluaciones estándar del EIDOS, del ADI. En las niñas siempre añadíamos una visita en ese grupo que está un poquitito por debajo del punto de corte, y cuando las veíamos en el contexto natural del colegio, en la mayoría de los casos nos pasaban. O sea que en mi experiencia clínica sí que tienen una mayor habilidad para mostrar una cierta reciprocidad social, y por eso salíamos a evaluarlas en el contexto natural. Ya.
Okay. For Clint, I think, what may be the importance of the so-called mirror neurons explaining the social cognition or influencing the social cognition?
Mirror neurons. Wonderful work coming from... Perdón? Neuronas espejo. Okay, neuronas espejo. Ahí vamos. So this is a wonderful work that came out of a laboratory in Italy in work with primates. Now, the notion there is that there is a particular part of the brain that subserves a capacity that could account for our ability to interact with others in the following way. The notion is that the same part of the brain is involved in the way that I perceive something as when I act on it. Say a monkey, for example, is observing somebody cracking a nut, or the monkey is cracking the nut himself or herself. So that's the idea, and it's become wonderfully influential, and people have been doing a great deal of research. It is the case, however, that two things could happen. One of them is that particular concept that something is involved in both observing and acting, which is something that sort of mirror neurons brought to the surface, is an attribute of the brain that is much more general than only the areas that have been associated with the mirror neuron system. In terms of its account of autism, it is interesting that if you follow that notion that there is something wrong with that system, children with autism would not be able to imitate others at all. And by imitation here, I'm not saying like pursuing an action in order to accomplish a goal. That's a higher level of imitation. What I'm saying is basically copying another person's gesture. And yet in autism, as the clinicians would know, you often have children who actually copy what you do. They copy anything that you do. And so they may start copying the way that you are babbling away, or they may be copying the gestures that you're making. And that's called echopraxia. And so according to the mirror neuron account of autism, echopraxia should be an impossibility. So what I'm saying is that it's very interesting. I think that we're all taking the mirror neuron a metaphor as something much more concrete than it actually is. And I think we had this wonderful discussion yesterday, I believe, that in some traditions, in psychology, but also in physiology and in neuroscience, the notion that the brain functions in this way, that the same area is involved in observing an act as well as in performing that act, is at the root of the way that anything is stored in the brain. For example, if it's often the case that when I'm trying to recall a very important experience in my life, that the neurons that were involved in first coding that experience and then storing are also triggered when I am remembering it. So those are the kinds of provisions that I would say. This is probably too much. But what I would say is that people should be concerned about unified theories of autism in general. That's one. And two, you have to be skeptical. And we're still learning a great deal about it. But that concept has really expanded tremendously. And I do believe that it means much more than the originators intended.
Unified theories is important to think about it, because what does, for instance, clumsiness has to do, and children with Asperger tend to be clumsy, with pedantic language or other traits? Because my point is, you cannot explain the various aspects of autism by a single mechanism or circuitry. And I do believe that you may inherit some traits and not others, and that would account for the difference in phenotypes. And I think there is some evidence for that when you think about specific language development disorder, for instance, and that when it's familial and the gene that was just discovered is also influential in autism.
I'll just say that, Frankie Happe's presentation yesterday in her paper, her review paper in Nature Neuroscience, made that point of the possibility that different aspects of the phenotype are in fact inherited separately. It's an interesting point.
But can I just comment on that? What about children with a single gene disorder, say in the SHANK3 on chromosome, the long arm of chromosome 22? They can either have autism, it's been shown in the same family, or Asperger's syndrome, and so a single gene can account for the triad of subdomains. In the main, maybe modified by environment. So how can one explain that a child has single gene loss, can have three aspects, full spectrum of autism, by that genetic deficit? I mean, how can you explain that then in that sort of in a triad of?
I would say that is the traditional view. I think what Frankie Happe was arguing yesterday, I believe it's kind of a new view. If you look at some other research, like, for example, John Constantino's work on the social responsiveness scale, however much he basically analyzes data, he comes up with one factor. Leo Kanner came up with one factor. And I believe that many people come up with one factor along the notions that those three, the triad that we use semantically to divide autism into three clusters so that we can make the diagnosis, those things come together more often than not, and that's one of the interesting things. And one thing, and it's a shame that Frank is not here, that it's an important for a developmentalist, a clinician to ask, is how can you have a social and a communication disability separately? Because I don't think I have met a person ever in my life who has a communication disability without a social deficit. In fact, it's hard for me to imagine why should we be social, not to be communicative, or to be communicative in not being social. I think that's it's hard. It's hard to separate those two things. I can certainly separate language, but language is a completely different matter. So I think it's something that would be better for Frankie to be here and tell us how do you account for that.
There has, in fact, I've forgotten the author, but you probably would know it, Amy, a recent re-evaluation of the a kind of different factor analysis of the various symptoms in autism and Asperger's syndrome, and coming up with the notion that it best fits actually a different triad, so that the social and communication are together, just from the point that Amy's just made, that you can't separate out. And, if you're trying to diagnose, if you look at the diagnostic criteria, you're often saying, is this what's this doing here and things. Whereas the diagnostic criteria also put play in with communication, which is very odd. And this re-evaluation has play as a separate dimension, and then has the third one being very similar to as it is now about rigidity and so on. No, I have no idea whether that's accurate.
I mentioned that, but I think that's by Gilberg's group, I think.
No.
Or another Scandinavian. It's a factor analysis of the AASQ. Yeah, the AASQ, I think.
I would just say one thing. I was involved in DSM-4. My colleague Fred Volkmar was directing the field trials, 19 centers around the country, around the world, and I assisted him in that work. I never found out if DSM-4 work is politically informed science or scientifically informed politics. It's very important for people to know that there is a process in coming up with definitions for disorders. And that there are many political, there are many social policy, as well as other concerns that go into coming up with those statements. That's statement number one. Statement number two, still, we take responsibility for the definition of autism. God knows how the definition of Asperger's syndrome came into that book, because I certainly don't know how. There was a notion that a political decision was made to include it in DSM-4, but not make it too different from autism, because otherwise it could somehow, do something to the boat. And so when people everywhere around the world use DSM-4 or ICD-10 as if these were statements of science, I would caution you Because, yes, to some extent they reflect results from a very large field trial. But there are many factors that go into coming up with those statements. And many here work as clinicians. So here is my word to clinicians. Our work begins with children. It begins with individuals. And don't ever, ever sort of give away your judgment and your understanding of that individual's profile of strengths and weaknesses because you want to make it conform to a bunch of statements that are great. Okay, they basically make it uniform, supposedly, around the world, the definition of those conditions. But don't believe that that's the beginning and the end of your clinical science. So in that sense, I am sometimes frustrated that we take something like DSM-4 and we apply multivariate statistics on large portions of data and come up with those kinds of conclusions. And to conclude, I just reviewed the paper from wonderful colleagues from some European country not far away from here. They took a very, 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 very large sample and they gave a particular kind of a protocol to them and they performed something called principal components analysis. You come up with 4 components and then you label those components. Now, one of those components ended up being leaky kidney syndrome. Now, I see that you're frowning because you probably haven't heard of that. I haven't heard about that either. So, so what I will say is that it's often the case that when we perform these very large studies using multivariate statistics, we still end up with 3 or 4 factors that we need to label and understand them. I still prefer to take a step back and take a face validity look at any of that work.
Well, we're running late. This has been a most interesting hour. It has. It has. But I think we should end, because there is a number of questions related to environment and autism. So perhaps we should end with a statement or a discussion about vaccines and autism, because they've piled up. Oh. So anyone wants to pick up this subject?
I wish I could remember his name. I'm terrible. It's the old age. But there's recently been a paper from a virologist in London, a lovely, lovely paper, re-evaluating the work that was done by Leahy in Dublin, which was the basis from which people thought that the MMR business had some validity, because he claimed to have found measles virus in the guts of children with autism. And this virologist has re-examined that data and shown, I think, to most people's satisfaction, certainly to mine, that they could not have been a measles virus. Now, whether there was a mistake, whether there was something more motivated going on, I don't know. But I really feel, and the meeting where the gentleman gave his work, there were parents in tears because they'd based their life on this understanding and thinking that the MMR had something to do with their autism. So I really do think we have to put it behind us and try to move on. The trouble with the MMR vaccine is that it happens at a time when, as we all know, the changes often occur in the development of children with autism. And as human beings, and human beings without autism, we're programmed to see a connection between events that happen in time. We can't stop ourselves. So it's very, very natural when you think you've got your beautiful baby and then something happens and, you know, maybe they've had a fever. And there have been other studies are saying maybe it's connected with the fever and how the fever is treated and things. But again, there's not good scientific proof of that. But the basic contention that MMR causes autism, I really feel we have to say that's, you know, there is no evidence for that belief and we need to move on from it. You know, we need to look at other things because, you know, it's like catching the wrong criminal, isn't it? We've caught the criminal, we put him in jail, and now we find out we've made a mistake. You know, it's not going to help. We need to get the real criminal. So it's not going to help us understand autism to put our mast on one thing we know is not right. So let's move on from that and let's try and stop other children dying of measles or getting autism through measles, and move on.
Yes, I promised myself some time ago that I would not leave a room like this without making a statement. So let me be very unequivocal. There are not many things that we know in this field for sure. This is one thing we know for sure. There have been many, many, many studies, population-based and more. There have been 2 reports by the National Academies of Science in the United States. There have been countless depositions. My good colleague from McGill in Canada, Eric Van Boon, could say what I'm just about to say in 3 hours. And it would drain you. But it would drain you because there is so much data supporting this statement that there is no connection between vaccination and autism. There is no connection between the preservative used in vaccines, called thimerosal, and autism. Now, there are many people who really feel strongly about this, particularly in the United States, because we often inherit the best of England. The case is thus. If there are pediatricians in this room, they should tell you that we need to vaccinate our children for many reasons. One of them is because children can die from measles. That's very important. Measles, in order for us to eradicate measles from our community, we need to have 95% of the population inoculated. In England, the situation is such that it's below that threshold. And now we have an epidemic of measles in England, and we're very likely to have an epidemic of measles in the United States. And children are beginning to die of this condition. Now, this is only measles. I'm not going to talk about mumps and rubella, but I can tell you that rubella is not a good disease either, because we know from the work that happened in the 60s and the rubella epidemics of the 60s, that if a mother gestating a child in the first trimester contracted rubella, that mother's offspring will be compromised. They'll have sensory abnormalities, they'll have intellectual disabilities and whatnot. So I know people feel very passionate about that, and we need to embrace those concerns of parents, absolutely. And for many parents, the issue is this. We, the community of investigators, don't have a cause for autism. And when you don't have a cause, people have 1,000 cures. And one of them is basically beginning to identify the culprit, because if I identify the culprit, maybe I can reverse the condition. So we understand it's human nature. Having said that, I would say this. A wonderful person, the person who discovered the rotavirus vaccine, and thanks to him, many children, now our hospital, for example, we are seeing a decrease in hospitalizations of children by about 40%. Now, that gentleman wrote a book recently called Autism's False Prophets, and it is exhaustive in its account of the data that goes against that hypothesis. That's number one. As well, I'm afraid to say, the sordid history of that hypothesis that has really victimized parents since 1997 and continues to do so because it preys on people's hopes. So once again, I think that we made that statement yesterday. It's okay to hope. It's actually wonderful to hope. But we should not trade on hope. And it's important for us as professionals, as clinicians, to also not to patronize parents. I think we have a mission to tell parents what we know. And I think in one sentence that our children really deserve more than our beliefs. Otherwise, they should go to the clergy. They come to you because you represent clinical science. And if they do so, it's, I think, our responsibility to say that the children deserve what is the best that science can offer. And that issue, the issue of vaccination, should really put to rest. And now I'm ready for the tomatoes.
What a wonderful way to. I guess we are all ready for the tomatoes. So once more, thank you so much for your for sharing your experience and wisdom and knowledge. And I apologize for all the hundreds of questions that have not been asked. See you later. Thank you.
Thank you. You have been the best moderator.
Sí, bueno, muchísimas gracias. La mesa yo creo que ha sido